Evaluating imaging features of intracranial meningiomas on MRI. This is presented by me, Dr. Sanket Girdhar, a radiology resident at BJ Medical College, Ahmedabad, and this paper explores the role of MRI in evaluating imaging features of intracranial meningiomas, and it discusses various imaging modalities including CT and MRI, which is used in diagnosing meningiomas, highlighting their typical appearance and associated features. This will also discuss the vascular features and will also try to differentiate between typical and atypical meningiomas based on MRI studies. Introduction. Meningiomas are common primary brain tumors and their accurate preoperative diagnosis is crucial for treatment planning. These are characterized into basically three histopathological grades. 90% of them are typically benign. 5 to 7% are atypical and 1 to 3% are anaplastic. High grade meningiomas are known to have malignant potential and typically recur after complete resection. MRI is the most common and most important imaging technique used for the detection and pre-operative evaluation of intracranial meningiomas. Previous studies have reported that pre-operative MRI is useful for grading meningiomas and evaluating their histopathological characteristic by analyzing imaging findings such as heterogeneous enhancement, marked peritumoral edema, irregular margins, and bone destruction. Modalities and diagnostic meningiomas. On a CT, meningiomas typically appear as homogeneous and hyperdense extraaxial masses which demonstrate homogeneous enhancement following contrast administration. They are classically associated with intratumoral calcifications. They also best demonstrate the bony changes associated with a meningioma. These changes include hyperostosis, osteolysis, and in the setting of an anterior skull base meningioma, pneumosinus dilation. Hyperostosis, which is most commonly associated bony finding, manifests as bony thickening on CT and is seen in mostly 25 to 49% of meningiomas, with the convexity and sphenoid being the most common locations. On MRI, meningiomas are usually hypo or iso-intense relative to cerebral cortex on T1 weighted sequences and iso to hyper-intense on T2 weighted sequences. On conventional MRI, meningioma hyperintensity on T2 weighted images and hypointensity on T1 weighted images serve as a surrogate for softer texture, while T2 hypointensity suggests firmer texture, although predictive value can be inconsistent. Additionally, the association of diffusion weighted imaging with meningioma texture has been variable, as iso-intensity on mean diffusivity maps suggestive of firmer texture in some studies. Tractography has been applied to resolve the course of cranial nerves from their nucleus of origin to the foramen of exit, as well as the optic chiasma and the pathway in relation to the skull base tumors, and helps in risk stratification in meningioma surgery. Meningiomas mostly take supply from the dural vessels, although they may also parasitize the bile supply from the carotid or vertebrobasilar circulation. These characteristics include a prominent central vascular pedicle from which smaller vessels radiate in a spoke wheel-like pattern. On conventional angiography, meningiomas usually demonstrate hypervascularity and a prominent tumor blush with delayed washout. These meningiomas can displace, encase, and narrow adjacent vessels and sometimes invade or occlude dural venous sinuses. MRI and CT play an important role in the demarcation of meningiomas for radiation planning. While tumor bulk and dural involvement are well appreciated on contrast enhanced MRI, fat-sat sequences are particularly useful for delineation of meningioma boundaries at the skull base and abutting venous sinuses. Tractography and high-resolution CSF sensitive sequences such as CIS can also be critical in helping identify cranial nerves during planning. The differentials for dural-based lesions include malignant differentials include hemangiopericytoma, lymphoma, melancytic lesions, EBV-associated smooth muscle tumors, Rosai-Dorfman disease, and metastatic lesion. The non-neoplastic processes include infectious and inflammatory entities such as TB and sarcoid, which may mimic mass. In some cases, neoplasms such as gliosarcoma may arise peripherally from the brain parenchyma, appearing to be dural based and even inciting a dural drain. This is a retrospective cross-sectional study that was conducted at a tertiary center. The inclusion criteria was extraaxial masses with broad-based dural attachment, giving a dural drain sign positive on post-contrast study. The exclusion criteria was extraaxial lesion with a known or a later diagnosed primary and extraaxial lesion with leptomeningeal enhancement or with signs of infective etiology. The study was conducted using a 1.5 Tesla MRI, Philips and Siemens magneton sample. The aims and objective of the study are to segregate the meningiomas into typical and atypical types on MRI brain studies, to assess the common locations of intraaxial and juxtacranial meningiomas, and to study the variants of meningiomas and atypical meningiomas. A total of 26 cases were evaluated based on the inclusion criteria. A female predominance was noted in the occurrence of meningioma, mainly in third decade of life. From the 26 cases that were studied, 8 lied in the convexity, 3 lied in the sphenoid, 2 lied in the middle cranial fossa, 4 in the posterior cranial fossa. The rest were in the CP angle, breezifrontal and parasagittal regions. Typical versus atypical meningiomas. Constellation of factors used for evaluating the meningiomas. Number 1, enhancement pattern, homogeneous versus heterogeneous enhancement patterns. The second is tumor margin, regular versus an irregular tumor margin. Tumor brain margin. A clear tumor brain interface was defined as meningiomas with a distinct CSF cleft between the tumor and brain parenchyma. Perilesional edema. While most of the studied lesions did not show any of the bony changes, presence of hyperostosis was considered as a feature of typical, while atypical meningiomas commonly invade overlying bone and scalp. Absence and presence of calcification were excluded from the criteria, which, however, support the typical meningiomas. DWI on restriction was also excluded from the criteria, since atypical meningiomas may or may not show diffusion restriction. ADC values depend on the fibrous content, so though the typical meningiomas show lower ADC values, both fall within the normal range as described for a meningioma. The dural mimics that were encountered were dural metastasis, dural lymphoma, tuberculosis, and solitary fibrous tumors. Coming to the images, this is a 36-year-old female with a T2 hypointense extraaxial lesion with regular tumoral margin and CSF cleft without any adjacent parenchymal and perilesional edema. There is homogeneous post-contrast enhancement. This is a classic meningioma. A sphenoid wing meningioma, atypical right swinging meningioma showing cystic areas within with regular tumoral margin and loss of CSF cleft sign. There is hyperostosis of the sphenoid wing. There is no definitive perilesional edema. There is also intraorbital extension. Cystic meningioma, a solid cystic extraaxial lesion in left parafalcine location with intraparenchymal cyst formation in the left frontoparietal lobe. This is another bilobed extraaxial lesion located adjacent to the dural sinus with erosion of the adjacent bone and extradural scalp component. There is heterogeneous enhancement with multiple flow voids within the lesion. To conclude, general imaging features of atypical meningiomas include indistinct tumor-brain interface, irregular tumor margins, inhomogeneous tumor appearances, and the lack of capsule-like enhancement at the tumoral margins. DWI shows restricted diffusion in cases of typical meningiomas. Common location of intracranial or juxtacranial meningiomas include convexity, parasagittal and falcine, sphenoid and middle cranial fossa, frontobasal, posterior fossa, including the tentorium cerebelli and cerebellar convexity, CP angle. The intraspinal meningiomas are about 1/9 of that of intracranial meningiomas. Many pathologies affecting the dura can mimic meningiomas. These primarily include neoplastic processes as well as infective and infectious and metastatic disease. While distincting this on imaging is difficult, there are many characteristic features which may help to point to the diagnosis. Thank you.